Hello and welcome to this short video in which we're going to cover some key principles for the assessment of professionalism in health professions education. This video is a basic introduction to the principles of how and why we assess professionalism the way that we do. It's aimed at anyone who is setting up this type of assessment to get you started, but it's also for learners who are going to be assessed this way to help them understand the basics of how and why these sorts of assessments happen. We'll use our fictitious University of Lobster as the setting for our assessment of professionalism, and we'll consider this assessment in the context of the principles of assessment that we've covered in other videos, things like validity, reliability, authenticity, and so on. These are the principles for the effective assessment of any type of domain, but pinning them down is quite difficult in the context of the assessment of professionalism. Let's start with validity. This is the most important feature of the design of any type of assessment. Is the assessment measuring what it's supposed to measure? Does it generate information that allows you to make the sorts of decisions that you want to make with that information? In this context, for example, does the assessment allow you to determine whether the learner is behaving according to the professional standards expected of the discipline? These professional standards are normally defined somewhere, for example by the professional body or the employer, but they're often quite abstract and difficult to pin down in precise, observable and measurable terms that we could use in the real world when we're making an assessment. There's also an additional tension in the definition and assessment of professionalism within health professions. When somebody starts a program of learning towards becoming a qualified health professional, they generally don't have all of the professional skills needed for practice. For example, someone's ability to communicate with service users in an empathetic and caring way. This is a professional skill, but it takes time to learn and is normally included as part of the curriculum. The challenge then becomes, how do we describe a person who has not yet acquired those skills? It would not really be fair to say that they are unprofessional, because unprofessional generally evokes a different set of behaviors. If we stick with the example from communication skills, someone who is unprofessional might be rude or inappropriate in their discussions with other people. A learner may yet not have learned the professional requirements of the discipline, but that doesn't mean that they are unprofessional. Let's unpack that a little bit more and consider some of the detail. Here is our generic learner, let's call them Pat. Pat wants to become a qualified healthcare professional. In order to do that, Pat has to learn a lot of clinical, practical, and other skills. A lot of these skills require the learning of professional behaviors, things like communication, respecting autonomy, privacy, and confidentiality, having difficult conversations about difficult topics, sensitivities to cultural, personal, and religious issues, and so on. These are all skills that become learned on the journey to becoming a qualified professional. However, there are some other professional behaviors that are less obviously tied directly to clinical practice. For example, is Pat on time? Is Pat dressed appropriately? Does Pat interact with their colleagues in an appropriate, responsible, and professional manner? Then there are some additional considerations. Pat is a human being. All human beings are subject to many pressures and strains. These sorts of pressures then influence how we might be able to act professionally. For example, we might find it harder to be caring and empathetic if we are ourselves struggling in our own professional lives, or if we've had a lack of sleep, or if there's something on our mind that's distracting us from our professional practice. This is normal. This happens to everybody. It's often outside our control. Yet we have to take it into account when we are assessing professional behaviors. Then there is life itself. Pat might, for example, go out for a meal, have a few drinks, and maybe have one too many. That might cause Pat to get into some sorts of difficulty as a result. This adds an additional level of detail and complication. If these sorts of things happen in the workplace, for example, if Pat has a few too many drinks and then goes into practice, that is clearly and obviously a professional violation. But if Pat is doing these things in their own time and they don't obviously directly impact their professional practice, should we still care about them? This then leads on to a bigger, more complicated, existential and very controversial topic. Is Pat a good person? Is Pat a virtuous person? Does Pat have the innate personality and other characteristics that we want in a healthcare professional? Assessing people's underlying personality traits or other innate characteristics and qualities is potentially challenging for a whole range of different ethical reasons, and is itself then affected by all of the other factors that we talked about. We all make mistakes, we all do things that we sometimes wish we hadn't, and that can impact on our professional practice. But does that make us a bad person? Does that make us not suitable to be a healthcare professional? How would we know? Is it even ethical or possible for us to find out? Let's take a second to consider these behavioral features that are perhaps not so obviously a part of professional practice. They don't directly relate to a clinical skill or procedure that someone might have to undertake. Why do we care about these? One of these main reasons for this is that there is an abundance of literature to suggest that these sorts of indirect unprofessional behaviors that are occurring outside of clinical practice do seem to predict future problems in actual clinical practice. People who end up in difficulty, let's say, with the law, or cheat on assessments, or they are late for practice or assignments, they are more likely to end up in a misconduct hearing that directly relates to professional encounter later on in their career. The literature on this is long-standing and it's not without its challenges and controversies, but it does seem to be fairly well established. There is a pattern, a link, a correlation between serious professional issues inside practice and serious professional issues occurring outside clinical practice. There is another validity issue here. These sorts of things, as we've said, can happen to anyone at some point. We've all done things that we wish we hadn't, and we're all subject to stresses and strains that we have little or no control over. How do we draw the line between someone who is just going through normal everyday turbulences of human existence and compare that to someone who we would say is not professional? The general way in which we would do that, the way we would distinguish between these things, is with repeated patterns of behavior. If these sorts of things keep happening, then it is more likely that there is a problem and that problem is eventually going to manifest directly in interactions with patients and service users. What counts as a repeated pattern of behavior then probably depends upon the severity of the behavior itself. Being late a few times is probably not as serious as getting into legal difficulties once or twice. There are a number of different assessments that can and have been used to assess professionalism in the health professions. Multi-source feedback is simply gathering feedback from multiple different sources. There can be professionalism-related items on checklists for things like OSCEs and workplace-based assessments, and we've covered these to an extent in other videos. Portfolios of practice, collecting evidence from multiple different sources around professional and other practice, including reflective accounts, reflective encounters, and many more. It's important to relate these to the different levels of practice that we've covered in other videos. One that we've used primarily is what we call Miller's Pyramid. Miller's Pyramid distinguishes between levels of expertise that a learner displays as they move through their training. All of the assessments that you see here on the left are generally related to the top part of Miller's Pyramid, the does part. They happen in the workplace. The knows and knows how levels of Miller's Pyramid can be important, but the does part of Miller's Pyramid is what really counts for professionalism assessments. There is no real point in asking someone in an MCQ about how they are supposed to be on time for clinic or whether it's okay to falsify medical records. You can write an essay on why cheating is a bad thing and why being on time is a good thing, but it doesn't really help you get to professionalism in the workplace. It's the doing of these behaviors that really matters. For the development of some professional aspects of direct clinical skills, these knowledge tests can be important. This high-level nature of assessments of professionalism does then lead to a good degree of authenticity in the overall assessment. Most of these assessments, as we just said, are taking place largely in the workplace and are being undertaken by a range of colleagues who are also in the workplace. The people who are doing the assessment are in the workplace, the people who are being assessed are in the workplace. None of these assessments is perfect and many of them overlap. So to consider the basic principles by which we assess professionalism, we're going to use just one, and that is multi-source feedback. Here then is one of our learners in the University of Lobster. Multi-source feedback, as the name suggests, is the collection of feedback from multiple sources. Here then we have one of our medical students at the University of Lobster. The feedback about that medical student is then going to be collected from other medical students, as well as from registered doctors, from other health professionals like nurses, pharmacists, midwives, and more. academic educators, practice managers, administrators, and perhaps most importantly, patients, service users, their families, and so on. When done correctly, multi-source feedback can potentially be a very powerful tool for evaluating the overall professionalism of an individual practitioner. Each one of the stakeholder groups that we've shown here might have a different perspective on the professional behaviors of the individual student in the middle. Each of the things that are important to those stakeholder groups are going to be different, and that potentially gives us a really authentic evaluation of the overall professionalism of that person. Here's one simple example from a study conducted by the UK regulator of medical education, the General Medical Council. They tested the following questions as a way of patients being able to give feedback on practitioners. Patients were asked to rate, in this case their doctor, on the following areas: being polite, making you feel at ease, listening to you, assessing your condition, and so on. These concepts then all relate to the basic idea of validity, the construct, the concept being tested. Here you can see that this range of questions clearly relates to the overall professional conduct of the doctor as they interact with the patient. As I said earlier, each of the stakeholders is going to have a different perspective and might be asking a different set of questions. Here are some examples of questions that peers are asked of their colleagues. You can see that the questions are different and are obviously more directly related to clinical practice. Colleagues are asked to rate their peers' clinical knowledge, diagnosis, clinical decision-making, and so on. Towards the bottom, there are some of these more perhaps softer skills, more interpersonal skills like time management, working effectively with colleagues, communication, supervision, and so on. The design of the individual questions for multi-source feedback, in order for them to be valid, has to follow the same basic principles that we've outlined in other videos, for example on the design of OSCE checklists. The basic principle is that we cannot read people's minds. We cannot get into their head to decide whether they are thinking like a dedicated professional. Instead, then, we focus on observable, measurable behaviors, and we word the items on that basis. The questions in the multi-source feedback are worded to try and capture observable, measurable behaviors where possible. In the case of multi-source feedback, though, these items are likely going to be more subjective than they are in the more practical aspects of OSCE checklist items designed to assess practical clinical skills. Let's move on then to some basic questions of reliability. Even if we ask a range of different stakeholders to give their feedback on PAT, there is a risk that they all have their own particular perspective on PAT based upon their interactions with them. For example, there might be a particular administrator that just really likes PAT based upon one or two interactions with them. There may be a couple of other students who really don't get on with PAT and have one or two negative interactions with them. Each of the individual stakeholders identified in this picture here is going to be subject to all of the same types of human factors that PAT themselves is subject to that we discussed in the previous slide. They're all going to have good days and bad days. They're all going to have different strains and pressures that act upon them. How do we then ensure that when we're asking these individuals to rate PAT, that their rating is fair, reliable, and valid? There's no real easy answer to this question other than the simple power of statistics. You get as many raters as possible. One particular good or bad rating is not going to be as significant in the overall rating of professionalism if there are multiple other ratings alongside it. If all of the ratings, and you have a lot of them, tend to say the same thing, well then that probably tells you something. If all of the patients are telling you that Pat has acted unprofessionally, then Pat has probably acted unprofessionally. Same with all of the other stakeholders. The precise numbers of individual raters that you need for a reliable rating is going to depend upon a number of factors. For example, the exact nature of the professionalism being evaluated, who's doing the evaluation, and who's being evaluated. In general, though, the numbers tend to be quite high. For example, a systematic review on professionalism assessment using multi-source feedback observed that we need 8 peer ratings, 8 senior colleague ratings, and 25 patient ratings in order to make an overall evaluation of a practitioner's professionalism. These are just example numbers, but they illustrate the principle that a lot of statistical power is needed. That then leads us on to the question of resource. Distributing, collating, and analyzing all of that data is quite a resource-intensive process. There are many well-validated and widely used tools for the collection of multi-source feedback, and it's probably better to start with one of those to design your own professionalism assessment from the ground up. That can lead on then to questions of inclusivity and equitability. These are fairly obvious questions when associated with people making judgments about other people, particularly when those folks are, what we might call lay folks, like service users who haven't been trained in the repeated delivery of feedback on practitioners. This issue is compounded by the fact that these types of assessments are obviously in person and face-to-face. It's not really possible to give multi-source feedback on someone who you haven't directly engaged with. And so all sorts of issues of unconscious bias then can bleed into the feedback that is being given on the practitioner. Again, the main tool to deal with this is the power of numbers. The more ratings we have and the greater diversity in the range and number of people giving the feedback, the more likely we are to be able to dilute out one or more biased responses. Training of all the participants involved is obviously desirable, but in particular in those doing the analysis. If they can spot patterns in the unconscious bias in the feedback about or from a particular learner or rater, then it may be a good opportunity to mitigate that challenge in the analysis and to instigate further training. Concerns about the potential bias and overall evaluation of individual performance can also lead to a negative learner experience. The sense that everybody is watching you all the time, and this can impact then how you are assessed and perceived in ways that maybe you don't feel like you have any particular control over. This can extend beyond the multi-source feedback into the domains that we talked about earlier. If someone is continuously worried that someone in a restaurant or a shop is going to report them for unprofessional behavior, then that can give the sense to the learner that they live in a state of constant surveillance, a sort of police state. They're never able to quite relax. This then impacts upon them, their experience, their mental health, and so on. One of the common ways to address this, and also to address some of the potential resource implications of multi-source feedback, is to ask the learners themselves to choose the stakeholders who will give them feedback. By choosing the individual practitioners, this can also motivate the learner. There are obviously some challenges with this though, back to validity and reliability. If a person is being assessed on their professionalism but selects the person making those assessments, then that may actually work to counteract some of the validity and reliability of the overall assessment. Once again, the answer to this probably comes from within the simple power of number and statistics. If we have enough people making the rating, if the learner is able to identify enough people to rate them, and those people are all able to give them positive ratings, then that's probably a good sign of their professionalism. Converse is true, of course, if the learner is not able to identify enough people to give them an overall positive rating because many people have concerns about their professionalism, then that will probably come out even if the learner is selecting their own raters. The compromise is normally to have a balance between feedback from raters who have been selected by the learner and feedback from raters who have been selected independently. In summary, effective multi-source feedback involves having a learner rated by multiple different stakeholders. Enough of those stakeholders are needed in order to be able to ensure that the overall assessment is reliable. By ensuring reliability, we go a long way to addressing some of the other challenges with these types of assessments, for example, bias, the student experience, and resource. The items by which the raters evaluate the learner need to be validated, authentic, and relevant to both the stakeholder's context and the overall professional practice in which the learner will be using those skills. By addressing all of the main components of effective assessment design, even something as simple as getting feedback on a learner can be turned into a robust and reliable measure of a complicated abstract concept like professionalism. That's it. Any questions about this, send me an email. Other videos that I've referred to are on the YouTube channel, and I'll see you in another video.